Go for it.
All right, what's up, guys? Welcome back. Pete and Drew here with another conversation. Today's conversation is literally a conversation. I have nothing planned based on what I want to talk about. I just kind of want to spitball some ideas off of you and get your opinion on some things, because I know you've been seeing clients that are probably older and more broken than myself, and I've been seeing some different kind of clients, and it's always thought-provoking for myself, like very thought-provoking, having to think differently client to client, and then just solving unique cases. And for me, even though a lot of times I'm training multiple people at a time, I'm always going to look into, like, what does this specific individual need? Because to me, it's going to be very different from person to person. And so, like, I don't know. For me in particular, I think it would be useful to maybe cover some case studies of clients of ours. I don't know if you have anyone in mind that you want to talk about first, Pete.
Sure. So what's up, everybody? So those of you that don't know, I'm finishing up my last clinical rotation at a neuro rehab setting up in a hospital in Springfield. So all I see is, patients with pretty severe neurological deficits, from TBIs to CVAs, Parkinson's disease, MS, Guillain-Barré, migraine strokes, which I didn't even know existed, but apparently they do. A bunch of stuff. So my mindset has certainly shifted a lot over the past 5 weeks, learning to assess different things and look for compensation patterns that are pretty obvious once you know how to look for them. And to be honest, like, I would love to say that most of the patients are older and it happens with age, but I'm working with a patient right now who's 27 years old who had a stroke. He had a left side MCA stroke. So those of you that aren't familiar with the anatomy of the brain, the left side is where our speech center is, Broca's and Wernicke's area. And the middle cerebral artery is what perfuses that area. So when you have a stroke at the MCA and in that region, it affects your speech. So your ability to articulate your thoughts and the ability for you to actually move your oral muscles to actually get the words out there. And it also affects, how you bring sentences together. Our ability to speak in full sentences is fluent, and, well, maybe not all the time, but for the most part, it's fluent. It's, it makes sense. It's logical. And when that part of your brain is affected, then it just doesn't happen. You speak gibberish sometimes, and it's just not logical thoughts, and the articulation is off. And some people don't even speak after, so it's different. But he is definitely one where I've been spending a lot of time with, close to 2 hours a day. And it's been a pleasure. It brings in some perspective, and it's been fun. So what would you like to know? What would you like for me to elaborate on? We'll use him as the first one.
Yeah, cool. I think that's an awesome person to start with. And I think the first question that comes to mind is, like, where do you start with someone like this?
Yeah.
And what are some of your, like, measurement? Like, what are you going to measure to determine your progress, if anything? Maybe it's not even anything.
Sure.
Go ahead.
So, keep in mind, when I first saw this individual, he was totally flaccid on his right side. Had no inclination of any sort of muscle contraction, no, trace twitching, nothing, right? Couldn't wiggle his toes, couldn't squeeze my hand, nothing, right? So it took a few days for that to come back. And, in the meantime, what you can do is assess passive range of motion. You can assess joint mobility. But that's not really going to tell you a lot about what you do as far as treatment. So in this particular setting, we had to wait a few days until he was able to get up out of bed, until we felt comfortable with him, walking around a little bit using an AD or, whatever it might be. And we just started with some objective measurement tools, just like you and I do, with our athletes, right? So, we did a Berg balance scale, we did a functional gait assessment, we did a tug, a timed up and go, we did a 5 times sit to stand for time. And, you know, it goes a level deeper though. What I've noticed is over the past few weeks, you can't just do this assessment to get a score. You need to look a level deeper. So, one of the questions on one of the objective measurement tools is like tandem walking, right? Heel to toe walking. So, if you can't get 3 steps in a row, then it's a 0. You don't score anything in that category. Okay, so he gets a 0, but why? Where does he lose his balance? What is causing him to lose his balance? Is it instability of the hip, of the knee, of the ankle? Is it his trunk? And these are things that you may not be able to pick up from the assessment tool, and that you will over time. But that's where we start. I think, and then obviously, like if he has difficulty with single limb stance, then there's your intervention right there, single limb stance, and then that gives you an opportunity to assess and evaluate at that deeper level. So with most of these outcome tools, except for the tug, you typically don't use an assistive device, right? So if you're doing, we'll take that same example, a single limb stance as your intervention, you can provide them with some upper extremity support and then really be able to take a step back and, what am I looking at here? Am I seeing a pelvic hip drop? Am I seeing a lateral trunk sway? Am I seeing, his knee hyperextension? Am I seeing his ankle doing anything, right? So it starts again with objective measurements because you need to establish a baseline. And I think that's true for anyone that we see. I don't care if you're a Major League Baseball league pitcher or if you're, this 27-year-old that had this really unfortunate stroke at such a young age. But it's got to start with something objective, and then you need to do a good job taking subjective information based off of that.
Cool. I love that. So I had a million thoughts as you were talking, and I loved everything you said. And those tests, I think, are great ones to use, especially for that particular individual, because obviously, first and foremost, like getting up from the ground matters, being able to actually walk matters. And so to me, essentially what I think about is why is it harder for him to stand on one leg than it is to maybe sit on the ground? And so in my head, it's like, oh, well, obviously there's less stability when you're standing on one leg than it is when you're on the ground because you have a wider base of support. You have more stability because you have a larger center of gravity. And so all these things that you're talking about, I think are going to work together. Like it's not going to, like, I don't always look at like, oh, it's the foot, it's the hip, it's the knee. A lot of times I'm looking at like, why is this person's center of gravity not where I want it to be when they're in gait? And so like a lot of times what I do is I'm going to start from the ground and I'm going to try to reposition things, from the ground, from the pelvis and the rib cage, and actually like try to affect their center of gravity a little bit more. And the way that I've been thinking about this is like a lot of times, we see different compensation patterns during gait. And it's easy to get hung up on like, okay, like that's where I see it, so I have to attack it from that particular position. But like, what if I saw someone who had like, a shifted center of gravity that's just more back toward their heels, or, they have a sway back posture, or they have trouble rotating, etc. Like I could go on, the list goes on.
Sure.
But that being said, if I put their back on the ground, that back is now in better posture. So now I have my hips aligned, my pelvis aligned with my rib cage, because the ground is a flat surface.
Mm-hmm.
And so like if I need to kind of affect someone's pelvic position, I'm just going to lay them on the ground so they have more stability on the ground and go from there. And a lot of times it becomes, okay, let's do something on the ground and then let's progress that same position into side lying. Let's progress that into quadruped. Let's progress that into half kneeling and then
Sure.
eventually work up towards standing and use seating. You know, you can use seated positions too. The challenge I think with that is like, okay, like where is the training effect? But a lot of times with these clients, you know, it is even in our head, like in our head, we're like, where's the training effect? But in their head, it's like, holy shit, this was hard.
Yeah.
You know, like even rolling on the ground, a lot of times is hard. And like, there's a lot to be said for training the rolling patterns. Like some of the DNS stuff I think is useful for people like this. But yeah, so go ahead.
And you know, I think too that that's super important to explore those different positions, because these particular subjects, they don't have the right midline orientation, right? Their perspective of what's center and what's neutral is off. You know, a lot of them, they don't have proprioception of the affected side of their paretic side. You know, they don't have sensation, they don't have motor control, right? Like you're essentially, you know, and luckily for this individual, his affected lower extremity came back quite well, to the point where now we're ascending stairs 2 steps at a time. You know, no upper extremity support. He's, you know, doing like some rotational med ball tosses with me. You know, he's doing very well, but that right side, that right arm just isn't coming back. You know, it's and it might over some time, but you know, the progress that limb has made over the past 2 weeks unfortunately isn't promising. But you know, I know one thing that we did look at with his balance was that he always lost his balance anteriorly and to the right. Okay. The right is his hemiparetic side. So he doesn't have trunk control to the right. You know, he lacks, and most strokes, what we'll find is that they have some sort of neglect on that affected side, right? Like, you know, it may not be like a perceptual deficit neglect where, you know, you only shave half your face or you only eat half the food on your plate, but like they just don't automatically look to the right as they would to the left. You know what I'm saying?
Yeah, for sure.
So I think that in itself is an important reason why we explored half kneeling first.
Mm-hmm.
And I think I was wrong in this, in that I could have done something quadruped, but I, being inexperienced, you know, was unsure if he would be able to wait there through the right arm. And, you know, I found out that he can, which is awesome. But, you know, I put him in a half kneeling position so he can get his midline orientation back. And, you know, first day, again, lost his balance, forward and to the right, forward and to the right, forward and to the right. But with enough cueing, and then, you know, with like some facilitation techniques for certain muscle groups, like if he was left knee down, right foot out in front, you know, we could do some facilitation techniques for right adductors and left obliques, you know, that anterior sling. And it was better, you know, and I think it's easier for him because he's young, he was previously active, and, you know, his prior level of function was relatively high. But I still think those same principles can be applied elsewhere.
Yeah, cool. Yeah, in my head, I'm thinking like, you know, just certain examples of people that I've worked with, and
Yeah, tell me about it.
well, I also do want to ask you one question too,
Sure. Yeah.
just to dive a little bit deeper into this guy. But I'm thinking in my head also. Well, actually, let me ask you first. So, like when he's walking, or what do you notice with his posture, other than that he just, you know, sways to the right or loses balance to the right? Like, what else do you notice with his posture?
So initially, you know, he had that lateral trunk lean to the affected side. He had really poor foot clearance on the affected side.
And this is all to the right. The right side is the affected side.
Correct. Yep.
Okay.
Yep. I'm sorry. When I say affected side, I mean right side.
It's okay. I just want
Um, you know, he had a little bit of a pelvic drop with the right single limb stance during stance phase. And then his ankle control is just really poor, where if he took the slightest step on a more narrow base. So I guess in more of like an adducted position,
Yep.
the ankle would roll an inversion.
Mhm.
So that was one thing that I really had to be careful of with him, because he may not feel it, but if you continue to add trauma to insult, right? Have this poor kid keep rolling his freaking ankle while you're trying to ambulate with him, like that's not going to make anything better.
Does he walk around without any assistance?
He
And
does now. Yep, he does now.
but
After
initially,
the first few days, he the acuity of his stroke was pretty severe initially, to the point where I was very unsure about his prognosis.
yeah,
But he bounced back relatively quickly. So we started with a cane. Typically you'll start with a walker because it has more stability and it's wider. But he started with a cane. It was rough. It was tough. It was tough to work through. It required a lot of attention on my end, a lot of guarding on my end. But now, like I said, he's walking at supervision level. Um, he had one thing I also did not mention is he had right knee hyperextension at initial contact. And then what you could see is, as he was progressively getting stronger and more motor control, that hyperextension no longer came at initial contact, but it did come between mid stance and terminal stance phase,
yeah.
as he went into more dorsiflexion, right? So, and now it's no longer there. So it's so interesting to watch the progression, so to speak, of the compensation strategies, because the body will find a way. That's what they do. They find a way to compensate and find the path of least resistance. But yeah, I mean, he's still awesome to work with. I'm fortunate that I get another week with him, and we're
Cool.
doing some higher level stuff right now where I can use my strength and conditioning toolbox, which is fun.
Yep. Cool. Yeah, no, I think that situation is similar to the one that I have with this older woman who has um, she essentially can't rotate, but her posture presents as swayed back. So when she steps, she sways a ton, like side to side. Yeah, like a ton. Very
That's
noticeable.
because her anonymous can't rotate, right? Or
Yeah, a lot of it's just she just can't rotate in general. You
what
know,
do you know what her diagnosis is?
dude, I think she's just old. She's very old.
Okay.
She
Old
has
and stuck. Yep.
yeah, she has shoulder pain, back pain. She saw a trainer prior to me. I don't think she's ever done PT. I know she does a ton of yoga. She's very flexible. Her straight leg raise is like her active straight leg raise is like literally over 100 degrees. Like
Mm.
it's absurd. She's super flexible, but she's just very swayed back. Like she's leaning back when she's walking, and she sways side to side, and she can't rotate. Her feet are very turned out, and so like we haven't really even done anything standing at all, because like I said before, her her center of gravity is just not in a good position. Like her center of mass is not in a position where she can maintain the right amount of pressure into the ground to manage gravity, is what I would say. And so a
Before you
lot,
go on, can I just ask like what her current level of function is? Like what is her current level of independence?
she's fine. She's totally independent.
No
And
assistive device, no
nope,
aid at home, nothing.
no, she's totally fine. She's walking around like this. And she told me like her grandsons are like, why do you walk like that? You sway side to side when you walk. Why do you do that? And she's had, I think, maybe the wrong thought process about it all. Like, maybe I just need to get more flexible and do yoga. Like I need to stand up straighter, things like that.
It's
Uh,
interesting that she's this flexible and yet walks as if she's a 2x4.
well, she's flexible, but she's not necessarily like, I wouldn't say her mobility is good.
Right, and there's a big difference between those two.
Right. And so with her, like I said, we're putting her on the ground, and I'm putting her on the ground and teaching her to rotate. So like I'm putting her on the ground and having her try to go like a cross, like do a cross connect on the ground is one of the ones that I've been working on with her. I've been working on like hip lifts with her, um, not necessarily like a bridge, but like a posterior tilt, and then making sure that she's actually understanding that lying on the ground and having her back in this position is the position that she should have with everything that we do. So she should have her pelvis and her rib cage in a straight line whenever we're in half kneeling, whenever we're doing seated positions, and whenever we're trying to work on her walking pattern. So that's something that I've been starting to use actually with a lot of clients is like, hey, like right now when you're lying on the ground, that's the same position that you should have with everything that we do is maintaining that good alignment so that for her in particular, like she doesn't think that this is good alignment when she's swayed back. So I think it's just that mindset shift has been helpful. But yeah, so like I've done stuff on her back. Initially was the first place that we started, and I also did a lot of stuff in sitting. I mean, so like I think with her, it's putting her in 90 degrees of hip flexion for the most part, at least on one side. Like I have one leg, like, and I think about it as this, like I think about it as like, how can I put her in the right position of gait so that when she is walking, she recognizes that position better. Like she now knows what that position is. And so we've
So
done, yeah,
so instead of having both hips and knees flexed, you're kind of only having one flex and one more in an extended position, as if we were
yeah,
walking, right? Like in double limb stance phase.
yeah. So with the cross connect, yes, but like, so for example, I've given her seated activities, but it's hip and shoulder rotation. Like, I don't know if you can see, hold on.
Mm-hmm.
So I'm here and I'm actually having her do this.
Mm-hmm. Mm-hmm.
So I'm rotating here and I'm coordinating the breaths. Okay, so now I'm sitting, and if you were watching from the side, you would be able to see like I'm not letting her do this, and every time she wants to do this, and every time I tell her, okay, we're going to pull the hip back and rotate the shoulder, it's okay, pull the hip back, and she tries to do this.
Mm-hmm.
And so I started to teach her like give an exhale, and you know what I mean, like stuff like that, and the breathing
Yeah.
helped with that too. And so that I think is a good realization for her. First and foremost is that like these things should start to rotate, and we have used the best that we've done so far is I'm ending the sessions with just a split squat iso hold. And when I say a split squat iso hold, it's like very, very shallow. But
Sure. Very soft knee bend.
right. And so like you said though, like she is very hyperextended, in her knees, and she's definitely a heel striker, and she's definitely like this with her feet
Mm-hmm.
turned out. And so, with the split squat, it's just trying to get her shin into mid stance or mid propulsion. And so that's the position. And I'm just making sure she understands like that she needs to make sure that her tibias and her feet are in a straight line. And then she's just holding on to that for 5 breaths. And we've worked up to 4 sets. So like, the majority of the session is spent on the ground or seated. If I do any kind of like resistance stuff, it's going to be on the ground or seated. And then the split squat iso hold is the only thing that we've done standing.
Cool.
I mean, obviously I'll look at her walk, but like if I tried to have her do like a march or anything, she just can't.
Sure.
She can't balance on one leg.
Yeah. So I have a couple questions if you don't mind. So how old is she?
She's got to be
Roughly.
Yeah, she's in her 80s for sure.
Oh wow. Okay. And so I understand she came from a much different training environment, with a different mentality, so to speak. Maybe not an environment, but different thought process behind what she needs. Is that right? Would you agree with that?
So I can't say for sure, but based on the conversations that we've had, she's told me that this is totally different from what she's learned before.
Okay. I'd buy into that right now without knowing anything else, just knowing you as a trainer.
Yeah.
So I gotta ask, like, what has her buy-in been like with only doing things on the floor and in a seated position?
Her buy-in is great. Like, initially it was, I had to learn a little bit about how she was as a mover. Um, and I think we both realized quickly there wasn't a ton of things that she could do.
Mm-hmm.
And I think she knows that. Now, she's definitely a tougher person, and she is currently in pain. And so my objective has become to explain to her why we are doing certain things. And I hope at least I've done a good job of explaining why we're doing the things the way we are doing them.
Mm-hmm.
And so I think she's bought into that. And I know, like, my development as a coach has been like, initially you kind of just throw things at people, but now I give people things with more intention, and my goal is always to explain why they're doing them. And with her, I probably spend a little bit more time explaining things than
Sure.
my average client.
So, talk to me a little bit about what she initially tried to do. You know, you mentioned before that that the both of you quickly realized that there was a lot that she could not do. Can you tell me a little bit about what those things were? Kind of what were the things that you were throwing, not throwing in there, but what are some of the things that you had planned that maybe didn't go so well, and then how did you adjust on the spot from there?
I didn't really have anything planned because the first session I did my eval on her.
Mm-hmm.
And basically so her goal coming in, and this is actually, I probably should have said this already. Her goal was to fix her gait. That's what she told me. My goal is to work on my gait.
It's good
Because,
awareness.
but dude, it was hard. It would be not hard not to realize that. And people have told her that is what she said.
Mm-hmm.
Goal is to fix the gait. She wants to move better, things of that nature. And so it was, all right, we're going to look at your gait. And that was what we did. And we looked at the gait. Um, I gave her some of my thoughts as far as what kinds of things are going to be helpful for her. And I looked at things like we said before, single leg balance, dynamic gait screening. I tried to do, like, I had her do a toe touch, and she can do that well. Um, the rotation was really bad. Like, she has a hard time doing a multi-segmental rotation. She has a really hard time doing like a lumbar locked quadruped rotation. So to me, it was like, oh, all right, yeah, like we just have to work on rotation. And that was really all I needed to know. Everything else just showed up as we went through different exercises. Like, I didn't jump right into doing anything too crazy.
Mm-hmm.
I think the hardest thing that I did with her on the first day was, like, I had her do, just so she felt like she was doing something, I had her do like a cable squat with a counterbalance. And that was like hard. Like, it was really hard. But what I did was I initially realized, like, okay, she's not gonna feel comfortable doing this. So I just put a box down there just to make sure that she wouldn't feel like she was gonna fall on her butt.
Sure.
Um, yeah.
Where is her pain? You said that she's in some pain. Where is her pain?
She comes in with a different pain every time. It's shoulder, it's neck, it's back. Um, I don't know. Like, there hasn't been a ton of other spots that she's mentioned so far, but we've only had 2 sessions.
Sure.
And so
Shoulder, neck, upper back, lower back.
lower back, it's been shoulder primarily on the left side.
And what
And
does
so
she attribute that to?
she says it comes out of nowhere. She said, like, she literally says that. And so I think she knows she just has to fix her movement, but she has very limited range of motion. Like, her shoulder flexion is really bad.
Mm-hmm.
Like, she has a lot of trouble moving her left arm.
Mm-hmm.
She has a lot of trouble even when I tell her to, like, bring her knee up into hip flexion. You know what I mean? Like, she just has a lot, like, she's very weak, very weak.
So I guess my next question is, let's bring it back to lifting her knee up. I think the shoulder is a completely different topic of conversation. We could touch on it as well, but regarding just the left hip, she has a hard time lifting up her left knee.
She has a hard time just lifting her legs in general, like when she's on the.
Do you think that's primarily because of weakness, or do you think it's more of a joint mobility issue? And I guess how would you try and determine the difference between the two of them?
No, I think it's more of like a neuromuscular issue, but I think it's also like an orientation issue, and she just doesn't recognize where that's supposed to be in the first
Mm-hmm.
place. Like I don't think I don't think she's done things like this in a long time, or even maybe has ever done them. She just doesn't really know exactly how to do them
Sure.
first and foremost. But that being said, there's clearly like a ton of weakness in pretty much everything in the anterior chain. Like her hip muscles are just super weak, and there's a tension and compression issue going on in a lot of different places. Really, to be honest with you.
Oh, he opened up a can of worms. All right, let's talk about it. Tell,
Uh,
tell me a little bit about the tension and compression issues that she's having.
uh, well, there's certain areas that she's going to be very compressed in, which just means like if you think about a certain area of space, like everything's being pulled towards each other, and
And
you know,
where do you find that is with her?
I would say I would say it's probably below the level of the greater trochanter. Like I would say it starts down there, and a lot of times that's going to be where it starts with most people. But she has just run into a situation where she has compression, probably just keeping it, it starts there, but then it's going up the chain. Put it that way. Um, so to me, she probably needs to feel some more tension. In different areas, like a lot of that stuff is coming from, so like a lot of that stuff is coming from like the lateral hip area. A lot of this stuff is coming from the lower back area. And so what we're trying to do is just create some tension in the front side of the body and teach her how to breathe so she can get some space, and transfer energy a little bit more effectively. So for me, it just becomes like, okay, like, let's learn to stabilize, like let's use the ground, let's use a chair for stability so that we can get some more tension into the right areas. And so that like the compression, like instead of being pulled so far in one direction, now we're starting to come a little bit more back to maybe where we want to be so that things are a little less compressed in that space.
So I know, I don't know a ton of his work. I probably should. Bill Hartman talks a lot about compression and tension. And I know he does a lot of breathing interventions for rib cage expansion and compression. And you were mentioning before how you would have her do the seated, hip and shoulder separation rotation exercise, including some breathing techniques. So, can you explain a little bit about how the breathing techniques will have an effect on compression below the greater trochanter, if it does at all?
Yeah. So this is like, I don't want to go too deep into it, but essentially like every time you inhale, it's a situation where you're getting like an expansion of the diaphragm,
Mm-hmm.
and like a distension. And then when you exhale, it's coming back up. And it's kind of like, I think of it as like almost like toothpaste. Like if you squeeze one spot, then air is going to go there, right? And then if you squeeze the other spot, it's going to go the other way. And so like if I'm going to push air into one spot, things are going to go the other way. And a lot of times, so like if I'm inhaling, things are going to happen up here, and then as a result, they're gonna happen down there. Does that make sense?
Yeah, absolutely.
Um, so that's the way that I think about it. And so with her in specific, I think the inhalation, a lot of times you're going to inhale as you're turning to the left. I think that's where she struggles too. I think she's a little bit more pushed to the right. And so I'm inhaling as she's going to the left to get a little bit more space on that left side. And then I'm exhaling as she goes to the right. Um, I don't know if I explained that well or not.
No, you did. That was good.
Okay, cool.
And I guess my last question, and forgive me if you already can sense the sarcasm that's coming out, but how much of her lack of mobility would you attribute to regular degenerative changes that comes with age?
Probably a good amount.
Yeah,
I don't think it helps that she is walking around with this orientation. Um, like her dynamic posture is not in a state of equilibrium, so to speak. Her dynamic posture is thrown back, and when she's in single leg stance, it's thrown back and it's off to the side. Um, so you can imagine what her foot looks like and her shoe looks like.
yeah.
Um, because that's what's attached to the ground. And so if I'm on my left foot and I'm all on my heel and I'm swaying over to the left, then what's going to happen to the shoe and what's going to happen to the foot? And I think you can fill in the blanks.
Mm-hmm.
So for me, it just becomes, all right, like there's a reason why things could be, and I don't know if this is actually true, but there's a reason why things could be feeling maybe worse for her than they do for someone else her age. Um, and it's not like it's her fault or it's anyone's fault, but if you have a maybe not ideal perceived center of gravity and maybe your perception of what good posture is isn't necessarily conducive to what we would consider good posture and good dynamic posture in gait, then a lot of times I think you're going to experience more pain and you're going to have trouble with, feeling like you're energized throughout the day because the system isn't working as it maybe should.
Sure. I think the last thing that we should probably touch upon to wrap up this episode is the idea of a training effect. And because, a lot of times, good coaches will address very minute things because that's what we see. And we believe that, you know, however small it may be, it has an effect elsewhere, which will have an effect elsewhere, and it's just going to migrate, right? Especially in the demographic that we are with athletes, where a lot of things are closed kinetic chain and biomechanics play a role and ground reaction forces play a role. So, I want to tell a quick story about another patient that I have um, who has a neurological deficit. She struggles with chronic migraines, and sometimes the migraines get to a point where she has stroke-like signs and symptoms. This has been going on for several years now, but they're progressively getting worse. And upon her most recent admission to the hospital, she had, a 10 out of 10 migraine and hemiparesis on her left side. Okay, this is her left now. So when I say paretic side or affected side, we're now referring to the left.
Yep.
So this particular patient presented with a posture, and the posture just gets worse the more fatigued she gets. So let me tell you a little bit about the posture. So the posture was lower limb only, so right lower extremity only. Left lower extremity only. I'm confusing myself now. And the posture was hip external rotation and foot supination. So if you can imagine, she could not get her first met head on the floor, could not pronate her foot, could not internally rotate the hip. Just that entire left lower limb was just totally out of alignment. So, going back to the training effect, what do you do, right? Like verbal cues aren't working. If we do a table test, so to speak, where I am assessing her available range and her joint mobility, besides a little bit of extra tone, there really wasn't much significantly different than the right side. So in that case, like, what do you do? So, for me, again, it's to your great point before, you change the position
Mhm.
and you reorient them to what is your neutral, right? So all we did was in sitting with a supported chair and armrest, we had her internally rotate at the hip, okay? And then literally I put, a sponge underneath her medial longitudinal arch, and I had her push down on the sponge, right? So there's your pronation. You can't get to the floor, I'm going to bring the floor to you. And we did that for 5 to 7 minutes, maybe. A couple of breaks in between, some education here and there, right? A little conversation. And we got her up and we walked, and sure as shit, she could then self correct with verbal cues. Was the posture still there? Absolutely. But if I said, turn that hip in or make the adjustment or find the ball of your first toe, the adjustment was there, right? I didn't have to, I didn't have to take my hands off of her. I could still guard her. I could still ensure that she's safe while we walk and while we do our transfers and whatnot. But, I do think that your point that you said before had a lot of value in that, it may not work for everybody, but if you have to change the position, then that's what you have to do. She was not getting it in standing. There was just too much going on. Her body just had too much stimulus, and she just could not focus her attention on what I was trying to get her to do. But as soon as you change the position, you don't have to worry about balance. Your anxiety is less. You don't have to worry about falling. You're supported in all the major surface areas of your body. And all you got to do is focus on two things, right? Pushing the inside of your foot down and turning the hip in.
Cool. I think with her too, you know, I think you probably get a lot of bang for your buck out of supine and sideline. Like I think if you lied her or laid her on her left side, and put her knee and hip into 90 degrees and dorsiflexed her ankle and maybe had her like use some sort of like maybe it's a right abduction against the wall. Maybe you're lying her on her left side and her left knee is hip height and her knee is bent and her ankle's in dorsiflexion, and she's kind of like pushing with the right leg. So everything is driving into that left hip while it's in flexion, internal rotation, adduction, and we're in dorsiflexion. That might help. That would be something I would maybe go to. Um, just brainstorming, like with
Yeah, no, I'm open to it. Yeah.
yeah, like that's a good thought. I think like with another thing that I've been doing um, with my patient that I just spoke about, or my client, is in half kneeling. I'm actually having her do like a floor, like almost like she's reaching for the floor, but I'm putting like a yoga block on the inside. So say her left foot is forward.
Mm-hmm.
I'll put like a yoga block on the inside of her left foot, and so she's reaching her right hand, right wrist, palm onto the yoga block, and then she's turned this way. So she's in, right? She's in mid stance on that left foot, and this is like she's already past heel strike, mid stance, and she's in a little bit of that right side rib rotation, and she's getting that same position where we're in hip flexion, internal adduction, internal rotation, adduction, and dorsiflexion.
Mm-hmm.
So those I felt have helped. Now it's not going to be something where I think yours was probably maybe even more effective, like right away, because that was something that she could like it provided maybe more context. But I think with this one, if you do it long term, I think this might make more of a like an actual structural adaptation, where yours to me is like now she can walk and that's like the best feeling ever. You know what I
Hmm.
mean? Like that's like you're providing context, and then now this person is able to use that in dynamic gait, where maybe some of these other drills are a little less, like they don't look like gait, or they don't look like
Right.
something that is super contextual to gait. But what they may be doing is providing a little bit more of that structural adaptation, if you're able to, I guess, get the right positions without any compensation.
Yeah, yeah, and honestly, I don't know if there's anything anatomically structurally wrong with this woman. I'm pretty confident that it's pretty symmetrical bilaterally. But what I will say is that I'm in a tough position for a multitude of reasons, right? Number one, I'm a student, so whatever I do that my CI does not agree with is not going to fly, right? And then number two, this is an acute rehab floor of a hospital, so we don't have a lot of time. And not saying that like any of these drills are going to take up too much time. I'm going to explore that a little bit more with you off the record, so I have that to go into tomorrow with. But we have maybe five to depend. I mean, it obviously depends on the person, but anywhere between 5 to 28 days with these people, right? And
Yeah, for sure. No, I'm not. By the way, I think your decision was right, and I'm not saying this is nothing to do with the decision you made,
no, of course, of course.
or if this is even the right exercise for this particular situation that you're in. But it's just basically a means to conversation for me.
For sure, and I love that, and I think what I wanted to talk to you about was other ways that we can do that positioning with this particular woman without laying her on her left side, because her left arm is still flaccid, and for her to just be laying on that probably isn't the best thing for her.
So then layer on her right side and do a left. So like put her on her right side, put her feet against the wall, make sure she's in 90 degrees of hip flexion, and then put a yoga block between the knees and have her pull her left hip back. So it would be like a left
The left.
left adductor pull back. So you're actually pulling back into that side.
So then she's going into hip internal rotation, adduction,
Yep.
and you think that good.
Not only that, it's creating that same like almost left turn is what I want to say.
Sure, sure.
Yeah. So
So
that
I guess my question for you is how much of that rotation do you think is playing into her posturing?
probably a ton.
You think so?
Because think about it this way: if my pelvic position is turned to the right, okay, but my left side didn't come along for the ride. Now where's my left hip, knee, ankle? See what I mean?
Yeah, I do. I follow you for sure. Um,
So that would be a situation where you have a lot of compression on the left side.
mhm,
So now you have to come in and create a little bit more of that tension. And so really what you're doing is the same thing that we were talking about before, is you're biasing that left turn with the pronation, internal rotation, adduction, and flexion. So because her foot is straight against the wall, right? And because you're turning like this with the hips, that is creating that same effect that you would get if you were to do that reach down.
mhm.
If you were to do kind of like that left side lying exercise, it would be very similar.
Interesting. Yeah, I'll have to play around with that a little bit. Explore some rotation stuff with her and see if that also has any sort of carryover. That's super interesting. I think it's hilarious that seconds before we hit the record button, we were like, let's just have a conversation, see where it goes. And I feel like I say this every fucking time, but like, I I I think this was one of the best, most in-depth conversations that we've had in a while.
Yeah, I agree. By the way, I think I might have been wrong about what I just said. Wrong. I think it was she would be in her right foot forward position, but it would still be doing the same thing that you're trying to get. because now her right knee's in front of her left. Yeah, I was wrong, but that's okay because it's still getting the same. It's still getting the same thing on the left side that you want.
You corrected it.
Yeah, I did correct it. Okay. Dude, I've been playing with this dart and I just dropped the top and it's pissing me off and I'm looking for it. I have a dartboard in my basement. It's kind of cool.
That is cool. That is cool. Nice. Well, that was a good conversation. I'm actually jacked up right now. Like, who thought that working with, two young guys like us who just love sports and competition and, just the ultimate athlete mentality. Who would have thought that like we could? Who would think that we can bring this stuff to the table with such a different person in front of you?
Yeah, I don't know.
And that's what it's about, right? Like, you may have to regress the exercise by 10, 12 steps, but it's still applicable, and you still have to draw those parallels.
It's the same thing. It's just shifting the scale, the intensity scale. It's the same intensity for this person as
Right.
a squat is for me or you.
Right.
And that's not a brag. I swear.
I hate split squats.
Yeah.
Nice.
Go ahead.
No, I was just going to ask if you had any other questions or anything else that you wanted to touch on, but that was more than fulfilling on my end.
Yeah, no, this was fun. I was a little nervous with the last thing that you're going to say about us. Like, I didn't know where you're going to go with that one, but that's why I started laughing. I didn't know if you're going to say, like, I just didn't know, but that's fine.
What did you think I was going to say that?
Oh, it was good. I didn't think you were going to say anything inappropriate at all.
When do I ever say inappropriate things?
You don't, actually.
Never.
You don't.
Never.
Yeah.
All right. Well, everyone, thank you very much for tuning in. Hope you learned a lot. I know I did. And this is the Pain Free Performance Podcast with Pete and Drew. I hope you have a good night.